Thank you, Dr. Unjun, and good morning, ladies and gentlemen. It's my great pleasure to come back to this 30th three-day symposium, and then this topic is the probably oldest topic in cardiology, because that as soon as the X-ray was invented, they begin to take the chest X-ray. And although it is old, I still find that it's very helpful in patient management. So what I would like to today is that the findings really in this simple imaging modality that should not be missed in patient management. As you know, the strength of chest radiography is the easiest to obtain and is very cheap. And then radiation dose is very little. However, it gives you excellent overview and then often provides clues to pathologies requiring urgent attention. Common indications in our hospital for chest radiograph is the known or suspected heart diseases, suspected complication of known heart disease, follow-up after medical or surgical treatment, and changes in clinical manifestations during patient management. What I would like to suggest is that when you have this first chest X-ray in your hands, look at this first. Not infrequently, chest radiographs can be taken from wrong person. So you need to check the ID first, and then also look at the radiographic technique, whether it is appropriate, there is any rotation, any inspiration, expiration type of things. And then look at the situs first, looking at the gastric bubble and then larger lobe of the liver and etc. And then heart position and aortic arch position. And then look at the heart size and configuration, and very importantly, pulmonary vascularity. And then also you need to look at the aorta, SVC and IVC, and then rest of the thorax. Okay, so let me start with the clinical examples. This is a newborn with a fetal diagnosis of heterotaxy, presumably right isomerism, unbalanced AVSD, total anomalous pulmonary venous connection. What do you see? Just I'm showing you cases. Take a challenge that here, what you see, what are abnormal. The first thing I would emphasize, look at the abdomen first. If you look at the stomach is in wrong place, right side. Not only it is in the right side, it's medially displaced, which is highly suggestive of transverse liver. So certainly the situs is abnormal. And then you find that there is a minor fissure on the same side of the stomach. Once you see this subtle finding, stomach and minor fissure on the same side, is heterotaxy with right isomerism by logic. Okay? And then in this case, confirming there is minor fissure on the other side too. You have bilateral minor fissures, which is certainly this patient has a heterotaxy with pulmonary right isomerism. And when you do the MRI, you can see the transverse liver and then atrial appendage right isomeric, and then AOA is isomeric too. Okay. Chest X-ray gives you some telltale signs of heterotaxy with right isomerism. Okay. Let's say you do echocardiography. Take a look at the chest X-ray, get the idea on what you will expect. So looking at the abdomen, if you have a horizontal liver, more likely to be right isomerism. Left isomerism can have a similar finding. Bilateral minor fissures, minor fissure on the same side of the stomach. And about in 20% of right isomerism, you can have the stomach in the thorax, not in other the cardiovascular situation. Okay? So here is another one, 5 weeks, newborn with enteroviral meningitis, left heart failure. Do you see anything wrong? Okay. Here you can see that there's some high signal intensity, bright area, here too. Okay. So this is very, very typical of myocardial calcification. Okay. So calcifying myocarditis. We quite often see that the enteroviral infection with myocarditis having rapidly developing calcification. Looking at this, 7 days just cardiomegaly, I don't see any calcification. But 11 days, knowing that this patient has, and then can you see the calcification here? So this is I'm showing you from the overt manifestation back into when you can see the calcification. Only 11 days, and few days you can see the calcification. Okay. So this is another 8-day male admitted through ER due to 3 days of lethargy and ventricular tachycardia, suspected enteroviral myocarditis. So here, 8 days cardiomegaly, but 16 days you have exactly the same finding. It's different patient, very similar. Okay? And then if you look at the 8 days, the echocardiography shows no positive signs for calcification. But however, 28 days, you can see that there are multiple spots of calcification here and there. Okay? And then this is a chest radiograph 8 days, and this is chest radiograph at 28 days. You can clearly see calcification. I would suggest to you, if you see this finding, period, this is a very classic of calcifying myocarditis. Okay, so here, there's similar finding here. Okay, so in retrospect, this subtle finding, you can feel that that is actually positive already in 10 days. Okay. So myocardial calcification, I find that it develops very, very rapidly in the newborn period. Okay. So this is the case with teenager with chronic dyspnea on exertion. Unfortunately, the patient apparently had a chest X-ray, but the chest X-ray was reported as normal, but collapsed and came to the ER, and then had the finding later on we found. Okay. So what you find here is that there is the prominent pulmonary arterial segment here. In the lateral view, can you see there is a mass here? So this is not mass, but dilated right pulmonary artery, dilated left pulmonary artery, making a mass in the hilar region, and peripheral vessels are not large. So this is a very typical finding of idiopathic pulmonary hypertension, showing that this bulge is due to dilated main pulmonary artery. In the lateral view, this is the complex of pulmonary arteries in the central location. Okay, so you have left pulmonary artery, right pulmonary artery making a large potato here with the small sprouts coming. So this is typical central peripheral discrepancy, and then there is the typical chest X-ray finding of pulmonary hypertension. The reason why I emphasize this is that if you know the diagnosis, it is easy, but especially radiologists should not miss this diagnosis in the plain films too. Okay, so this is a comparison. This is normal chest lateral view. You see right and left the pulmonary artery is not very large here. That makes the huge mass. Okay, this is a teenager with known pulmonary hypertension. So you have a prominent pulmonary arterial segment, and lungs appear a little bit dirty. Vessels not clearly visualized, although they are shown. Okay. So the patient was on oxygen and the vasodilator therapy, and then after that, you see that more edema in this patient. What it is in this case is in the CT, you can see that the interlobular septal thickening everywhere, and then there is the kind of mosaic pattern of density, which is typical because the pulmonary veins are patent, and then there is a pulmonary hypertension. CT shows typical interstitial edema, and this is typical pulmonary veno-occlusive disease. So both are pulmonary hypertension. On your right side is idiopathic pulmonary hypertension. There, you can see vessels are still clean. But however, on your left side, pulmonary hypertension, however, vessels are blurry. And then you have some septal lines here and there. It is a rare diagnosis, but you might not want to give the vasodilator for the patient on the left side. Okay. This is another one as a newborn with a severe tachypnea. In newborn, heart size is normal, situs is normal, and then you can see the both lungs are diffusely hazy, but the lung volumes are reasonably good. but the vessel margins are not clean. And then this is so-called reticular pattern in both lungs. This is typically seen in interstitial pulmonary edema, most commonly in obstructive total anomalous pulmonary venous connection. But, however, it is also seen in hypoplastic left heart syndrome with restrictive ASD. And then you can have lymphangiectasia. Findings will be a little bit different. I will show you lymphangiectasia later. And then also you can have congenital interstitial pneumonia or newborn interstitial pneumonia. Okay. So on your right side is a hypoplastic left side is a hypoplastic left heart syndrome with restrictive ASD, almost identical finding. On your right side is pneumonia. What is the difference? Left side findings are very, very evenly distributed, homogeneous, while on the right side, pneumonia, you have some regional differences significantly. So there is a simple difference. Okay. So this is the case of obstructive TAPVC. So you can see that the retrograde catheter is through the brachiocephalic vein and the vertical vein and coming into the common pulmonary vein, you can see almost complete obstruction. So it is stented, successfully stented. I will show you the chest X-ray here because we didn't have a better chest X-ray before. I show that after stent placement. You can see very, very reticular, the thick interstitial densities. I don't have your numeric criteria how thick it should be when you call lymphangiectasia, but it's too severe to be simply pulmonary edema alone. And this is typical finding of lymphangiectasia. Okay. So anybody who wants to challenge the diagnosis, this is a 15-year girl with chest pain and dyspnea. As a radiologist, I don't have any idea what it means by T-wave inversion at V1 to 3 and QRS at 90 degrees. Okay. Do you have any suggested diagnosis from the chest X-ray? Chest X-ray actually is very, very classic, and it's diagnostic, actually. You may want to see the lateral view. Why? When you have pectus excavatum, you will have a similar finding, but there isn't pectus excavatum, okay? So what it is in this case is that in the MRI or CT, there is a very, very subtle finding. What it is that this is the main pulmonary artery, this is the ascending aorta, this is superior vena cava. Normally, surgeons knows well, there is pericardial coverage here. So therefore, lung tissue cannot be between the main pulmonary artery ascending aorta, but in this patient is invaginating, which means that there is no pericardium in this location. And then heart is dripping down into the left thorax, okay? That's why you have a chest X-ray finding of this. And if you see this finding in the absence of pectus excavatum, it is the diagnosis. Okay, complete absence of pericardium. Okay. So this is another interesting finding. I emphasize this one. Why? I have seen multiple cases. These patients were under antibiotic therapy for a long time, multiple times. This is a 7-month girl with clinical signs of pneumonia. Okay. What do you see? So this is the 3 months earlier, similar finding. Finding is that the left lung is small. And then there is something in the right side, okay? So the outside reading of chest X-ray suspected pneumonia, but they are not quite sure what's going on. But however, in this case, if you look at the chest X-ray very carefully, so left lung is hypoplastic. How do I know? Lung volume is small and trachea is displaced to the left side. And then there is one more finding. Can you see this one here? So descending aorta is on the right side, which means that this should have a right aortic arch. In the presence of right aortic arch with the small left lung, this is the diagnosis. So in angiography, MPA gives rise to the right pulmonary artery, but no left pulmonary artery. There is a right aortic arch, there is the diverticulum here, and there is small pulmonary artery in the left lung at the hilum, which means that there is a ligamentum ductus arteriosus. So diagnosis of this is this. So ligamental ductal origin of LPA typically in right aortic arch. Okay? So if you are especially radiologists thought about this possibility, the patient did not have to have a multiple the antibiotic treatment. Okay. So this is another one, 15-day born at 27 weeks, increased oxygen requirement, echo showed absent right pulmonary artery. So this is actually typical finding of another ligamental ductal origin of right pulmonary artery, so which is right lung is severely hypoplastic and trachea is displaced toward that. Heart is also following the displacement. Okay, so this is the CT scan. You can see absence of mediastinal segment of right pulmonary artery. The small right pulmonary artery is here. And then you can see from the left aortic arch, this is the right brachiocephalic artery. There is the small duct coming down. Okay? So if you find that this disease at this stage, and then your cardiologist can probe this one and then put the stent in and then make the RPA growing for later the unifocalization of right and left together. So therefore, plain film diagnosis, if you miss this one for a couple of months, and then you will not have that opportunity to make the right pulmonary artery grow better. Okay. So interesting is that ductal origin of a branch pulmonary artery, either right or left, ductal origin of right pulmonary artery almost always occurs with the left aortic arch. Ductal origin of the left pulmonary artery almost always occurs with right aortic arch. Okay? Therefore, in this case, right aortic arch with the small left lung is the telltale sign to the right diagnosis. Do you see anything here? So again, you have your right lung hypoplasia, and then in the lateral view, you have a very hazy thing behind the sternum. Okay? So that is called the retrosternal hazy band. Okay? So this is a typical finding of scimitar syndrome. We don't know why, but when you have a scimitar syndrome, the mediastinum lung interface is in this way. So therefore, if you take the lateral view, this margin is shown as the vertical shadow with the increased haziness in front. Okay? So this finding, not completely diagnostic, but highly suggestive of scimitar syndrome, especially in the presence of right lung hypoplasia. Okay? So unilateral small lung, differential diagnosis include scimitar syndrome, ductal origin of the right or left pulmonary artery, unilateral pulmonary artery stenosis, unilateral pulmonary vein obstruction too. And then once these diagnoses are excluded, this could be congenital unilateral lung hypoplasia. Okay. So this is very important. 2-year goal with increased work of breathing, history of VSD repair at 5 months. When the VSD was closed, nothing wrong, but however, came back at 2 years with some problems. Chest X-ray is very typical. What it is that left lung has the prominent vessels and right lung has decreased vessels, okay? And then you have some pleural the effusion here, and then some reticular pattern in the right lung. So this is very, very suggestive of development of unilateral pulmonary vein stenosis. Okay? So in the CT scan, you can see complete obstruction of the right pulmonary veins. If you have a right pulmonary vein obstruction, blood flow goes to the other side. Therefore, you have increased blood flow in the left lung and decreased flow in the right lung, and then findings of interstitial pulmonary edema. Problem of a sort of congenital pulmonary vein stenosis is what? Substrate for future development of stenosis might be present already in utero, but clinical manifestation, phenotypic manifestation can be delayed. That is a very annoying thing, especially to surgeons. I did the right thing, but the patient develops pulmonary vein obstruction. Okay? We have seen multiple cases like this, actually. Okay, so this is the case showing abnormal descending aortic contour in the Takayasu arteritis, okay, the complicating Crohn's disease. And ascending aorta are prominent, and then you have this. And then whenever you have a descending aorta like this, it is either neoplastic condition or the aneurysm of descending aorta, okay? In this case, 20-year goal with dyspnea requiring oxygen. Here you have your silhouette rather large. But silhouette is pencil sharp, very, very clear, okay? And then this is very the strong telltale sign, especially when it is associated with pleural effusion, pericardial effusion shown here, okay? Okay, so this is an 11-year male with history of Kawasaki disease, okay? Can you see that small coin here? Okay, so that is the calcification of the coronary arteries. Okay, so here in the angiography, you can see calcified aneurysm might have some mural thrombus. Okay, in the lateral view, same thing. Okay, so you can see that. So in retrospect, there is the large aneurysm here, and then those are calcified. Okay. So 12-year girl with the Alcapa repair, chest pain. If you have anything like this, very abrupt change, especially with the almost normal pulmonary vascularity, and that is pericardial effusion. Okay. 4-year child with the AVSD repair. Okay. So post-surgically, you have a wide superior mediastinum. Don't be shy in describing there is some collection. Okay. In the CT, you can see a large amount of mediastinal collection. Okay. So 7 days after surgery, you can see unilateral elevation of a right hemidiaphragm. And then what is your diagnostic modality to choose if you suspect the unilateral phrenic nerve paralysis? So ultrasound, M mode. You have right diaphragm not moving, left diaphragm moving. Okay. 3 months infant with a PDA. Just newborn. Can you see that there's some halo of lucency here? So this is a typical medial pneumothorax, because most of the chest X-ray are taken in the supine position. Small to moderate amount of pneumothorax accumulates along the cardiac silhouette. Okay, so that is a typical medial pneumothorax. Okay. So here in this case, you can see that on the left side, right side, there is a pneumothorax. Okay. And then can you see that some tubular the structures here in the upper lung? I'm not showing this finding. So what it is here is that they developed a pneumothorax with interstitial pulmonary emphysema. I want to show this one back here. Actually, finding of interstitial emphysema was there a few days ago already. So these lucency, tubular, but not really following the expected caliber change of normal bronchi. So it's tubular, but not tapering out. And then there is a very typical side of interstitial pulmonary emphysema. And then you might not want to do too much positive pressure on ventilating, because that you may have a pneumothorax later on. Okay? 8 months infant with a history of seizures, intubated. What do you see? So there is some triangular shadow here, some lucency here. So that is a typical finding of so-called Spinnaker sail sign. So what is triangular here is this thymus elevated because of the pneumomediastinum. Okay? Finally, 21-day hypopressive left heart syndrome, 15 days after nodal operation, slowed rate of feeding, and hematochezia. Do you see anything? So in chest X-ray, you can see something wrong here. What are these? This is a typical finding of air in portal veins, which is seen in patients with the pneumatosis. So the patient has necrotizing enterocolitis. You can see in the abdomen typical findings of pneumatosis. Okay. So here that the another one that they're developing left lung, the collapse with endotracheal tube into the right main bronchus. It's not infrequent, honestly. Okay. Okay. So to list that I suggest you don't miss important clues to the rare unrecognized diagnosis: asymmetric pulmonary vascularity, very good in chest X-ray. And calcifications, any calcifications, post-op ICU complications, including any abnormal air, including pulmonary interstitium, pleura, pericardial cavities, and bowel and liver. And acute change in lung volumes, just check the ETT position. Thank you very much for your attention.